everybody, and welcome to our September Quality Leader session. I'm Peggy Peterson. I'm one of the Quality Improvement Specialists, and I'm going to be introducing our speaker. I have a couple announcements before that. We're going to have you put any comments or any questions in the chat, and we'll address those at the end of the presentation. And I'd like to welcome everybody. And this session is being recorded, and it will be on YouTube under Constellation Quality Health, and it'll be available next week. And any of the previous sessions for quality leaders is also available there on that site. So at this time, I'd like to introduce our speaker, Jewel Coleman. Jewel is a registered nurse, and Jewel is a quality improvement specialist with Constellation Quality Health. And she's going to be speaking to us on infection control, vaccinations, antibiotic stewardship, tracking, and training. And many of you know Jewel from her Department of Public Health role. And I'd like to tell you a little bit about Jewel and her experience. And Jewel's recognized as a subject matter expert in nursing homes and infection prevention with proven expertise in clinical assessment, OSHA, CDC, CMS regulations, and staff development. Jewel served as a consultant and long-term care certified infection preventionist with the South Carolina Department of Public Health, supporting nursing homes statewide, and as an infection preventionist and staff development coordinator and QAPI coordinator with long-term care facilities. So thank you and welcome, Jewel.
Thank y'all. I am delighted to be here. For those of you who know me already, y'all know that I am not one to read every word on the slides. And if you don't want to wait till next week to get them, I will be more than happy to send y'all a copy. But I do so much talking, I've decided lots of times that it's easier if I just advance the slides, give you an overview, because you're going to get them and go from there. And one of the reasons that we're going to do it at the end is I found myself finding that maybe a question that comes up early on may be answered later during the presentation. So we'll go back to that and go from there. So we're going to get started. Okay, infection control in 2025. And of course, the VATT stands for Vaccines, Antibiotic Stewardship, Tracking, and Training. For all of us, we know that there's so much more that goes with this. We've got environmental cleaning, we've got disinfection, we've got communication, we've got isolation, or if you want to call it isolation, we've got sending people to the right place, housings and things like that. And we've got that word called documentation. That is definitely one of those things that we all know if you didn't document it, it didn't count. And one of the biggest things that I think we fail to realize sometimes, no matter how hard we try, that we have to teach our residents. We have to teach these families, and we have to teach our staff. Among these, especially in the antibiotic stewardship role, are our physicians, because we know how easy it is for them to just sometimes, and I don't mean take the easy way out, but when the family member comes and says, oh, mom's got a UTI, just know it, put her on some antibiotics. You know, we know that sometimes our physicians are going to give in. So we have to have our physicians on board. It truly does take the village. Okay, let's start with our vaccines. Seasonal vaccines are needed in order to promote the wellness of our residents, as well as our visitors. We need to be encouraging them. We need to be talking to them. We need to keep them on board so they don't come into our facilities sick when they shouldn't be in. We've got to make it so that it's not spreading into our village, not coming into our buildings. And that's a biggie, because sometimes people have already infected us before they know they were truly sick enough not to come in. But that is a huge part of this. Vaccine programs are an integral part of the overall infection prevention part, and CMS is all over this. The F883 speaks to established requirements for these vaccines and what they have to talk about. You have to talk about those influenza vaccines. By the way, I got mine yesterday. Pneumococcal vaccine, mine is still up to date. Then we have to document the education part of this. And this is where I want to tell you that right now we have so many people, whether it's through miscommunication about what these things are. We've got people that are vaccine hesitant for so many reasons. We have people who are vaccine fatigued that don't want to even hear about getting another shot of any kind. What CMS is saying and what they are requiring is that you have to document that you have educated these residents, their significant others, their point of contacts, whatever, on the value of these. If you administer them, if they refuse, please get a signed refusal that they refused it. And if they have medical contraindications, why that person did not get that. You're going to find this under Appendix PP in your state operations manual, but those are the big keys. If we educate our residents, if they say no, then they're going to say no. They may change their mind. Hopefully some will, hopefully some won't, but make sure you have the documentation to prove that you have done at least that much. And here's just a copy of the SOM or the state operation manual. This is what the surveyors in our facilities are looking at. They're going to check for those things that we talked about, that documentation, that education, that signed refusal, that's there. And this is a biggie right now on the survey, because we know they're not doing anymore unless it's under a complaint. They are not doing true infection control surveys. That has been deleted from the new survey. But come on, guys, what's one of the biggest things people complain about? They didn't tell mama this. Daddy didn't know about this. Nobody took time to explain this to us. So yes, it's still going to come up in complaints, and there's still going to be times when a facility does get a true pilot infection control survey on the F888 or the F883, but for the general part, it's only going to come in complaints. So if you can make all of these things already, and I hate to use the word checkboxed off, but documented, then you're good, because that much has already been done. You can pull out that information, you can give it to them. Do not forget that you're also responsible for educating your staff. At the same time, you're responsible for educating your residents and their families. You have to educate your staff. You also have to give them an available option to go get these vaccines if it's not something you offer in your facility. If they choose to say no, okay, they chose to say no like everybody else. But again, make sure that in their charts, in their files, it is documented that they were educated on not just the benefits, but all the contraindications, why you feel like as a facility you need them to have them. Some people in their policies, remember what your policies say in your facility. You may have a policy that says if they don't get the flu vaccine, they have to wear masks or something like that. So make sure that you are educating your staff to everything that follows your policy and procedure, so that, again, you can present this to survey if they come in, and not just because we want to practice to survey, but we want to do the right thing by our residents, our staff, and our visitors. Addressing vaccine needs and requirements. And you're going to hear this over and over and over throughout the presentation, because this is simply where we're left right now. Educate your staff, educate your residents, educate your families and responsible parties. Please, if you have vendors coming in, if you have contracted people, let's just say you use an agency for some of your staffing, make sure they have this on their file and can send it to you. It's hard sometimes when you're pulling an immediate staff member from a staffing agency to come in, but let's don't get caught without having the documentation on them as well. Again, document it. Was there a medical contraindication? You notice how we left off the religious exemption here, because right now CMS is not looking at the religious exemptions on a lot of these, but that doesn't mean that a particular surveyor will not come up and say, okay, well, there wasn't a medical contraindication. Is there another reason? So just make sure you have all of that. And then again, consent or denial, administrative the part of this is it documented? When, what, how much, where, and any adverse effects or lack of effects. Again, going by your policy, are they going to wear that mask? Does your facility require them to do that? What are you doing to make sure you're in compliance with your own policy? Okay, antibiotic stewardship. One of my favorite things that I have always loved since we put this in, and this is where I go back to talking about my physicians being on board with this. Very simply, it's really so easy when you think about the true background of it. Make sure that you're not doing anything that is unnecessary. Make sure the patient has a condition that will actually respond to the antibiotic, that they truly need it, that they still need it. This is where your antibiotic timeouts come in. Some people will just automatically put somebody on something for 7 days or 10 days or whatever. Are you doing the right dosages for the right amount of time? And then you have to consider the risk that if they get this antibiotic this time, are you risking giving them a chance to get an opportunist infection? And so many times that happens. I think everybody on here could probably think of numerous times that your patient, unfortunately, let's just say they stumped their toe. They went to the ER because the family demanded that they go, even though y'all could have handled that in the nursing home. And we know how these families are, but they went to the ER. Well, guess what? They went to the ER and guess what they said? Oh, well, they were confused when they stumped their toe. I think they have a UTI. Well, chances are they didn't. They probably had some asymptomatic bacteria that showed up in there. But guess what? They're coming back on an antibiotic. So this is the times that you really need to dig down. Call that hospital. Did they send a culture? Is it really a UTI? Or do you just take them at their word because they stumped their toe, knocked off their toenail, and while you're dressing their toenail, you're putting them on an antibiotic for really probably something that shouldn't even be treated with that particular antibiotic. So we have to be good stewards. We have to be the educators. We have to explain, particularly with our nursing home patients, when you're talking about elderly. One thing that I don't think we talk about enough are the side effects of some of these antibiotics on the elderly. People have a lot of underlying medical conditions, whether it's heart, COPD, HIV, whatever it may be. Are you really going to take that chance with this person to give them this and make their kidneys fail? Are you really going to take a chance with them to do this where maybe you don't have to do it and you just monitor it a little bit closer? And that's the kind of things that not just your IP thinks about. That's the kind of things every staff member needs to think about. Okay, F881. Well, let me just tell you, if you get an F881 tag, you've already got the F880 tag, because we're not lucky enough to just get usually one tag cited out of the list of infection control things. You're going to get pretty much a lot of them that go together. Okay, the FF80 falls under 48380. You must establish, maintain, and control a program or a prevention and control program to be safe, sanitary, comfortable, and here's the big kicker, to prevent the development and transmission of communicable disease and infections. This includes a lot of things, but one of the biggest things are a trained IP, one who has that certification saying that they went through this, that they are a part of the QAPI process, that IP is listed in QAPI, that you have a consulting pharmacist. Every long-term care has to have a pharmacist, whether it's inside, outside, whatever. Are they reviewing these? Do you have notes where your pharmacist came in and said, to the doctor, maybe this wasn't such a good idea. Could we go ahead and cut this back to 4 days? Or do you really want to keep this antibiotic up, considering that they take this med, and this med as well? Bring in your pharmacist. Let them help you with this. Antibiotic stewardship. This has always been one of my favorite things to tell you, and I'm going to tell you, it says between 40 and 75. It is on the high end. So I'm just going to pick a number, 65% of antibiotics prescribed in nursing homes may be unnecessary. I can tell you that a lot of them are totally unnecessary. And what do we see these given for? asymptomatic UTIs, in my world, asymptomatic bacteriuria. Sinusitis, we don't treat sinuses and bronchitis the same way that we used to, because we've learned a lot of these are viral. And if we don't remember anything else, we need to know that an antibiotic is not going to take care of a virus, including COVID. And then again, bronchitis is listed under there. 100% of residents in a long-term care center may carry a bacteria that indicate a possible UTI, but don't have an active UTI. What do they have? Maybe some dehydration. Maybe they need a fluid challenge. Maybe they need some other things that go along with just getting them back to square one. But Miss Jones, who went out for that toenail that got taken off, does not really have a UTI. So you have to stop this before it ever gets started. The prevalence of asymptomatic bacteria in different populations, and this is just a general rundown, boys, girls, females, males, however you want to look at it, healthy women, people with diabetes, older adults, and this is where I love to look at this. The women are 25 to 50%, where the men are 15 to 50, because most men do not characterize their urinary tract. Again, bacteriuria, the way that women do. Women have a higher portal of holding on to some of this. Then you have the special populations like spinal cord injuries, people who've had a transplant. What do we know about any transplant? They're immunocompromised from the beginning. So are we just going to load them up on an antibiotic again to further compromise them? And then we have those people that, for whatever reason, still have that indwelling catheter. Have we tried to get rid of that catheter? Hopefully we have. We don't need CAUTI on top of everything else getting caught in there. But when you look at the days here, when you look at the times that this happens, you see that these things happen over and over and over. But here's the important part of all of these numbers. Is it colonization? If it is, what did we put into effect just a few months ago? Enhanced barrier precautions. And this is the reason why this is there, and this is the reason why it's so important to remember these people need to stay on this for their duration in your facility. It is not a quick hit and miss. It is not contact precautions. It is enhanced barrier precautions. They could be colonized. They're going to hold on to this. It doesn't mean they can't transmit it to someone else, though, okay? And what do we see? The change in mental status. That's the first thing the families always talk about. And unfortunately, some of our nursing staff, well, she acted just like this when she had that UTI. Oh my goodness, it must be an episode of her COPD coming in. She's really hacking in there and carrying on. I don't think it's just a bronchitis. I think there's something else going on. So we call the x-ray people. We call these people. And then when we call the doctor, unfortunately, what does he say? Oh, well, let's just put him on a Z-Pack or something. It'll be, no, we've got to stop that. We've got to stop the process of giving unnecessary antibiotics for lots of different reasons. And here are your core elements of antibiotic stewardship, your leadership. And I know that's most of you guys on this call. You have to be committed to this. You have to make it a priority. You have to be accountable. And here we go with our physicians. Let them talk to the pharmacist. Let the pharmacist talk to them. Your drug expertise. What actions are you taking? The tracking, the reporting, the education. Are you really doing a full gambit of trying to make antibiotic stewardship work in your facility? When I was in my last facility, I gave out report cards on a monthly basis I had 3 attendings and my medical director. And it was amazing once they started getting these report cards, they would ask me, how did Dr. X do? Well, is he a lot better at this than I am? You know, they're competitive. So you have to get them on your side as well. Again, you're not just educating your residents, you are educating everybody in your building. The 4 moments of making that decision, and this is where I really wish we could preach to our physicians to not give up on this. Does the resident have symptoms that suggest it's really an infection? Well, what kind of infection is it? Did we get a culture before we started the antibiotics? Do we really need to give them empirical treatment? Do we know how long we want this to last? Or are we just going to go by the 7 to 10 day thing? And it's been 2 or 3 days since we started the antibiotic. And maybe we need to take a look at this and reevaluate. You know, these are things that we really, really need to look at. That patient that went to the ER. Again, in our program before I joined public health, we put a thing in that we monitored our residents for 48 hours. We hydrated them. We did all kinds of different things before we sent them out, unless, and that's the big unless, the family was determined they had to go out right that second because mama was just going to die if we didn't send her out right that second. And then she's going to come back with that toenail again that also says she has a UTI, and we're caught between a rock and a hard place to come to find out they never even did a culture. They just made assuming things. That was a big thing for me where I was prior. I met with our ED physicians and our hospital leadership on a monthly basis. We talked about these things. We needed them to know this is what we want in our facility. And I'm sorry we had to send this patient to you, but we didn't have the right to refuse what the family wanted. But please help us be good stewards, help us learn what we need to do. And it was probably one of the most effective things getting our local emergency department on board with us, because that stopped a lot of this by itself. F881, again, we're going back to these words: safe, sanitary, comfortable, and preventing the spread. That's where we have to be when survey comes in. We have to talk about, did we check for that culture? Did we educate? Did we question our ER physicians? Did we question? Did we educate? Did we train all of our staff to really know what we were looking for before we just empirically started that antibiotic? And then again, we've talked about the main ones, the V, the A, the T, and the T, but let's talk about the environmental aspects. Indoor air quality. If y'all have read anything since COVID came out, you will see that this is one of the biggest things that both CDC and CMS promoted after they declared an end to the pandemic. Let's make sure you have good air quality circulating through your facility. Well, some of our facilities, like myself, are older than dirt, and they may not have the best, heating and air conditioning systems. They may not have the best of the structural things. So what have you done to address that? How have you addressed that? 81 of the nursing homes, including there's 12 of us guys here in South Carolina that used ultraviolet air purification system. They could not really afford, and there's so many times that a lot of these things cause us to either close our doors or try to make modifications and still make some sort of improvement. And we all know that's a big risk. They flush hydrogen peroxide through the air sometimes. They truly showed statistically that it decreased the number of the weekly COVID cases back when we had COVID. And I love this little diagram over here because we all know during COVID, we were wearing masks. We were breathing our own breath in over and over and over. Our visitors, when visitation was opened back up, they were wearing masks, hopefully. We had people that, as you well know, staff included sometimes, that didn't wear their mask properly. We had people that had their mask under their nose. We had people that never truly got fitted for their respirator. So all of these things played a huge part about what we learned during this particular respiratory time during these years of COVID. But we have made some changes, and there are changes out there that can be made. And we just have to show the people that this is what we have done. And we've tried to make these examples. And I love all three of these pictures, because what do we have here? What is the number one reason that we continue to spread things? Because we don't wash our hands the right way at the right time. We don't change our gloves at the right time. We touch something else. We are our own worst enemies. The latest statistics tell you that the healthcare population really adheres to hand hygiene the way it should be at about a 44% level. That is kind of scary. That is kind of scary. So this sweet little man over here who looks to me like he would live in assisted living probably got sick, or could have certainly got sick, because we had to break an aseptic technique ourselves. We didn't do the right thing before we went over there to make sure Mr. Man was okay. And then the lady down here that we're talking to in the bottom picture. Okay. I was very much a touchy-feely, huggy-lovey person with my residents. I made a point to see them, touch them every day when I went in, and touch them every night when I left at the end of my shift. That was just something, because some of these people had no one else. But I always made sure that I did it the best way I could, and I didn't, if it was an emergency, that was a different thing. You know, if I had to run in there for something, I might not have done everything I needed to before I cracked that door open. But otherwise, I did it. And you know what I did? I also went in there at different times during the day, and I would say things like, the meal trays are coming. Let me go ahead and wash my hands in case you need some help when your tray gets here. And let's wash yours too. Because y'all, that's something we forget about all the time. We forget to wash our residents' hands. We might scrub ours up good, but did we scrub those? Did we scrub theirs up good? You know, there's all kind of ways that you can convince people to let you help them without sometimes them knowing you're doing the right thing. Training and tracking, which is first? Well, you got to train and you got to track, but how do all of these rails, as depicted in this picture, fit together? Which one first? Well, let me tell you something. If you're not telling me or training me to what I know that I need to look for, and then all the incidentals that may pop up, I'll figure them out along the way. Am I really going to know what I need to track if I haven't been trained? Yes, tracking is a very, very important part. And your infection control people know this. But how do they do it? Basically, that's left up to each facility, again, going back to your own procedures and policies. But let me tell you, you better have your training ahead of time to know what you're tracking. Okay. Are you going to use a line list? Are you going to use a risk assessment? You should use both, in my opinion. Are you mapping out your units? Do you know your building well enough to know where people roam freely in this ward, but maybe they don't run freely over on the other section? Are you looking at group activities? Are you looking at communal dining? Are you looking at the whole picture of your building, or are you just isolating one unit and thinking about the precautions that you need to take there, or in my case, the proactive measures that you need to take there? Know your risk. This is probably one of my favorite tools that CDC still has out, the ICAR. When I first retired, when I first retired for the 37 hours that I was retired, and then went to work for the Department of Public Health, this was one of my favorite things that we did at first. Again, this was right in the throes of COVID, before we even knew that COVID had a name. We just knew that there was a lot going on. There was this funky respiratory thing going on. We had no idea what it was going to be. We didn't know anything about it. And we called every nursing home. There was a group of us, and we called every nursing home in the state of South Carolina, because I worked for the South Carolina Department of Health and Environmental Control at the time, now South Carolina Department of Health. And we did risk assessments. We did this ICAR, and that is still so prevalent even today. And if we don't think about anything else, think about the cool mornings that we're having. And I can say this. I told Olivia and Peggy, who are my constants today on this series, that the sun was just beaming in my window so much today, I didn't know if I'd be able to see my slides. But I also know that when I went out first thing this morning to make sure the kids next door, my grandchildren next door, were up and ready to get to school, it was kind of fall in the air, and I was so excited. Now it's hot out there. You know, by the time today is over, I'll probably be in shorts and a t-shirt again, because that's what we have here in our world. So, you know, it's important to get to each facility and know what is special about yours. Are the facilities in the upstate the same as the facilities along the coast? Same as the facilities in the low country? Absolutely not. We're bringing in different types of infections. We're bringing in some of the standards to everywhere. After COVID, we're bringing in Legionella because there were so many things that water safety was not being checked, or water wasn't being, we weren't flushing toilets. We weren't running in these hotel rooms. We weren't keeping up with the water processes. We've got so much out there. So you have to know everything about your facility that makes it unique to some of the other things. And this is one of the best ways to do it, is through this iCard tool. This is an example of a line list. We went back at the Department of Health. We were actually instructed back in the day not to ask for a line list anymore. I may have been a little against that, and I'll be honest, because it was one of the easiest ways for me to do it. You know, we had facilities that had not registered yet or could not get registered for NHSN, so they weren't tracking logistically. So those line lists were very helpful to us. And did we get used to not asking for them? Yes. Did we love the facilities that still sent them to us? Absolutely. Did we love making these infection control visits just to see what we saw from a different set of eyes? Absolutely. We were very proactive in all of that. And did it make a difference? I think it did. Well, in my heart, I know it did. And then these are the resources that we used for this presentation. And we've talked about a lot of things today. We've also talked about the Jewel's opinion on a lot of this, and how that, you know, we can learn from each other. You know, we can share with each other. There was a time during COVID, and if a facility didn't have to do it, I'm surprised that we had shortage of supplies. So we would ask a sister facility to loan us some gowns, load us some hand sanitizer. You know, when I say it takes a village, it takes an entire village. These are the people that are taking care of our loved ones. If nothing scares me more, heading to year 70 of my life here, this scares me. One of the biggest things, who's going to take care of me? Are they going to be trained properly? Are they going to know what I need, despite the fact that I'm going to try to still be the boss, even in my demeaning mind? I think I'm going to tell them what I want to tell them, and they're going to listen to me. Are they going to be able to take care of me? And then further down the road, who's going to take care of my children? Who's going to make sure that my grandkids get the vaccines before they go to school? You know, there's so much out there that we have to take our own individually responsibilities for. But then there's so much if we just follow the basic science. There's a links and wealth of tools for long-term care. There's tools for our kids. There's toolkits put together. I just saw one yesterday that CDC put out for the upcoming fall respiratory virus season. You know, there's so much improper communication going on. If you ask Google and Facebook, they're going to tell you you have a brain tumor before you get finished searching for your sinusitis that you have, that you don't need those antibiotics for, but you'll be convinced. You know, there's so many things out there that really have started to take the place of the natural science that we know and that we should be able to trust. We just have to make sure that we are promoting that we are teaching that we are documenting it. And if somebody still says no, then unfortunately, they still say no. And here's some additional resources that you can pull up. Lots of these have some really good things. If you haven't taken a look at Appendix PP in your state operations manual, I would encourage you to go back, take a look at that, because that's where, again, I don't practice to survey, I don't preach to survey, but that's going to keep you from getting those civil monetary penalties if someone comes in. And then we are going to open this up for further discussion and any questions that came in or any comments, because I know y'all are tired of hearing the Jewel version on all of this that is going on. So Peggy, I'm going to turn it back over to you.
Okay, thank you, Jewel. And I'm going to open up to the group. Does anybody have any questions? I know one thing that probably is in everybody's mind is, you know, vaccine, the season for flu and pneumonia, and is coming up October 1st. And also a lot of information's out there with the COVID vaccine and the new vaccine that's coming out with the updated medication. Jewel, do you have anything to add about that?
No, not really. I do know that a lot of folks have told me, and I actually had my doctor's appointment yesterday for my 6-month checkup, and I went ahead and got my flu vaccine when I was there, and I asked about the COVID vaccine, and of course they were out of it because they don't have this new version of, some people are calling it boosters. But if some of these, even though I'm well over the age of 65, I could go to a pharmacy and get mine. But if you are not over the age of 65, have proof of immunocompromisation, if you go to your CVS, your Walgreens, or whatever, they're going to make you have a doctor's order for the new one. I think most everybody is pretty much aware of that. And a lot of people aren't going to go that far. But y'all, we have people that are immunocompromised that we don't ever even think about in our families, in our nursing homes. There's a thing that CMS says and has gone through the pharmacy board. If you take more than 20 milligrams of prednisone or some sort of steroid per day, that makes you immunocompromised. We don't think about that. We think about our cancer patients. We think about our HIV patients. We think about the people who've not lost their natural immunities, the 65 and over population. But a lot of facilities have younger people that are also immunocompromised. So we have to take all of that into consideration. But if anybody else has heard more about this, please share with me, because I don't have the loops that I used to have to all of this. So if anybody has any more information that they could share with us, we'd love for you to share with us.
Okay, well, if you do, and or you have any other resources, please drop it in the chat for us. And at this time, I also like to invite you to attend our October session for quality nurse leaders, for quality leaders. And that's on October 16th at 11 a.m. It's going to be Amanda Borgarelli, who is the COO for Positive Approach to Care. And she works with Teepa Snow. And Amanda's specialty is teaching the practical, effective care methods for caring for patients and residents with dementia. And she did a little presentation for us last year along with Teepa, and it was very good. And we will also be recording that as well.
And I'm going to ask you guys that when you get the survey that comes at the end of our quality leader session, to please be very bluntly honest in there. I used to be one of those people that would NA this or not do something. We are looking for what keeps you awake at night in your facilities. What doesn't let you go peacefully to sleep? Can we rewrite the regulations? No, but we want to hear what topics you need us to help with you guys. You could put something on there that we may not even be aware of. It's a learning process for this entire village as we do this together. So please, 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 if you are a subject matter expert in something or you have a best practice, hit us up. We'd love to hear you talk about some of this stuff. We're looking for speakers. We're looking for people to help us. Please don't be so bashful when you fill these things out to say, no, whatever you want to do is fine with me, because we really, really, really want the interaction with each other. That's how we learn.
All right. Well, great. And thank you again. And we look forward to hearing your comments on the survey at the end of this session. And, please put any additional topics you'd like to see covered. And we look forward to seeing you in October. Take care, everybody.
Bye, everybody. Thank you for coming.